بسم الله الرحمن الرحيم. أبنائي طلبة سنة تانية، اليوم يمكن هي المحاضرة الفاينل في الكورس of the anatomy of the cardiovascular system، اللي هو عبارة عن الانتجريتد، جزء من الانتجريتد كورس تبع الكارديوفاسكولار سيستم. by integration we mean اللي هو بيجمع الاناتومي والفسيولوجي والباثولوجي and related issues. الحقيقة أنا فضلت الموضوع هذا يكون في النهاية، لأنه لما بنعرف the normal structures of the heart and the great vessels بنقدر نعرف الأنوماليز ونقدر نستوعبها بطريقة أكثر الحقيقة. في المحاضرة هذه we shall be able to know the embryological basis of the heart and the great vessels development. And by great vessels we mean the aorta, the pulmonary valve, the superior vena cava and the inferior vena cava. وهذا كتير مهم صراحة. نمرة 2 we shall be able to understand the different stages of heart chambers and heart valves development. الحاجة الثالثة اللي هو we shall be able to have an idea about some congenital heart disease. وهنا هي فكرة دراسة الاناتومي including embryological defects which could happen during organogenesis of the fetus in utero. وهذا clinical entity كتير مهمة الحقيقة، وهذه فكرة دراسة الاناتومي and embryology. الحاجة الأخيرة we are to review some of the great vessels anomalies، وهي هذه كتير مهمة. لما أتكلم على double arch of the aorta، لما أتكلم على some ectopic sites of some of the big vessels اللي طالعة من arch of the aorta أو vena cava، سواء inferior vena cava being double being absent، وهذا كله clinical entities yes rare but we are to know because in our lab we could meet across such anomalies. زي ما احنا عارفين our tissues in the body are composed of three main entities بصراحة. three main layers, three main germinal layers, let us express it, and we are calling this and the embryonic disc or epiblast, and this is for an ectodermal layer, mesodermal layer and endodermal layer. And from those three layers our tissues and organs being manufactured. Look at this diagram or this figure really, which is the human embryo disc at 18 days. It's a three-quarter view really. Here is the embryo being implanted in the uterus, and this is the body stalk, and in this are the three layers, and those are the three layers of embryogenesis. I mean ectoderm and mesoderm, then coming to the endoderm, which is forming the lining epithelium of our systems and the digestive tracts linings. This is the body stalk, and this is very important really just to keep it in mind, because this picture will be repeated in the coming figures fairly frequent. Of course, here is the amniotic cavity, and here is the amnion, and this is the yolk sac. And in the middle, you know, always our structures are being symmetrically developed from a right and left say later on will be. But this picture is very critical just to keep it in mind. An ectodermal layer here, a mesodermal layer here, and endodermal layer in here. Again, in the embryonic disc is being divided. Looking at it and coming to the mesoderm specifically here, division of the mesoderm into three parts. Look at it, symmetrical parts on the right and on the left. Here is the notochord. Notochord, as you know, it is forming the nucleus pulposus of our vertebral bodies really. And if we are looking at the mesoderm being differentiated into three parts, the somites here, and those are 40 pairs of body segments in repeated units like building blocks and in 4 weeks. Then coming to the intermediate mesoderm here. For intermediate mesoderm here is developing only the kidneys and the gonads. Each part is developing something. And coming to the lateral plate. And lateral plate is being divided into splanchnic mesoderm and coming to the somatic mesoderm. This is very important because we shall talk about the splanchnic mesoderm where our heart and big vessels is being formed of. It's very important again to keep this in mind. This is the embryonic disc, right and left, notochord, and the mesoderm being differentiated into, again, I am repeating, into somites in here, intermediate mesoderm, and lateral plate. The mesodermal lateral plate will be divided, as we mentioned, into somatic mesoderm opposing the ectoderm in here. And coming to the splanchnic mesoderm opposing, just opposite the splanchnic mesoderm. The coelom, which is the cavity surrounding our big structure, some of the serous cavities of our the ventral body cavities, and specifically we are talking about peritoneal cavity, pericardial cavity here, and the pleural cavity in between those two somatic those somatic mesoderm and splanchnic mesoderm. Let us have this diagram just to have this in mind. Always keep it in mind. This is very beneficial for all our system of the body when being developed in utero. Here is the epiplast or embryonic disc, as we are mentioning. We are having the mesoderm in the middle in here. We're having the endoderm in here. Then we are having the ectoderm. For the mesoderm, it is differentiated into, as we said, symmetrically on the right and left side. Here is the intermediate mesoderm, or here the somites, and here the notochord in the middle, and this is one side of the body. The other side is having the same nomenclature. Notochord in here, somites in here, intermediate mesoderm, then lateral plate mesoderm. Lateral plate mesoderm is giving the splanchnic mesoderm, and the splanchnic mesoderm is giving our heart and the blood vessels, as we mentioned earlier in the previous slides. But it's beneficial to have a complete idea about our system, how being developed inside or in utero, I mean. The heart is coming. If we are to talk about the heart, how being formed, there is something in the looking at this figure in here. It's a dorsal view of the late pre-somite, before the somite being formed in utero, approximately about the 18 to 19 days. There is the embryonic cardiogenic field is established by mesoderm just after gastrulation. And this is developed into fully functional multi-chambered heart, fully functioning multi-chambered heart by the 8th weeks of gestation. And here are the and being developed or composed mainly of angiogenic cell clusters or angioblasts or hemangioblasts, we are calling that. And those are being differentiated into both right endocardial tube and left dorsal right the dorsal aorta. We shall talk about this later. Again, coming to the embryonic disc. Here between the here is the splanchnic mesoderm, and here our endoderm. Here the angiogenic cells or blood islands developing the blood vessels. Here in between, just look at it, please. This is the splanchnic mesoderm, and this is the endoderm, and in this area are developing our heart and the great vessels. And if we are looking more specifically, developing during development of the cranial or caudal part of the embryonic disc, we are having this in the cardiogenic fold starting to form here, the pericardial cavity, and the angiogenic cells is going to give us the heart and the big vessels. During the heart, development or position of the heart is established by our heart is in our left hemithorax, we are calling that. Its position is being remodeled or positioned by two mechanisms. One of them is the cephalocadal or a cranial folding. Both are folding, craniocaudal folding or a cranial folding, and the lateral, or at the same time, there is simultaneous lateral fold. So there are two foldings of our body, and those are simultaneously happening together. At the same time, a cranial folding, this is the cranium of our embryonal disc. And where is here is the cranium will develop. I mean, the cranium, the brain, and the other the neurological tissues and related structures, and the lateral folding at the same time. Look at it, please. If we are talking about the cranial folding, but before going to that, let us have the differentiate the details of this developing embryonic disc. Here we are having the developing brain. Here is the notochord, and here is the oropharyngeal membrane. The same in the next, other progressive stages of development. And here is the pericardial sac, and here is the heart tube, which will be formed later, as we will see from right and left primordia. And here is the septum transversum connected to amnion. This, coming here, by more development, there will be some sort of rotation of the cardiogenic area. The cardiogenic area will be rotated, moving it ventrally to the ventral aspect and to the caudal aspect. The brain being grown or growing more rapidly than other parts of the embryonic disc. So as if it is will be pushing the heart tube more caudally so as to come in its place in the thorax. So the brain is coming in here, developing the brain in here, and due to the rapid growth of the brain, and our heart tube and pericardium will be just coming caudal to that, coming to its position in the chest. Of course, okay, this is the ectoderm, and the spinal cord is coming in here, and here is the foregut, here is the heart tube, and here is the pericardium. Just try to stress and read this and concentrate on this figures. So the first folding is the cranial folding, what we call cephalocadal folding. Then we shall come to the next one, which is the lateral folding. Here we are having the two primordia of the heart tubes, the right and left tubes. Those are both of them will be laterally. If we are looking to this figure, and this is the embryonic disc again, and we are having the tubes right and left primordia of the heart tubes. Those will be rotating or folding laterally so as to form at the end one tube, So one tube from here and one tube from here, they are coming from, according to this diagram, a sagittal one, and growing progressively till they are coming in here in the middle, and having the heart tube, single heart tube, surrounded by the pericardium, and this heart tube will be composed of cardiac jelly, and this is the endocardial tube, and this is the myocardium, the future heart coming. So the lateral folding will be opposed by pair two heart tubes, primordia, and dorsal aorta to the middle, heart primordia fused to form the tubular heart, or the heart tube, from which the heart will be differentiated into these different chambers and the great vessels come you. So the cardiac loop, please keep this cardiac loop in mind all the time whenever you are coming. The two primordial, the right and left tubes will be fusing together due to the lateral folding, as we mentioned earlier, and their position by just lateral folding, or the craniocaudal folding. Here by date 121, as we said really, whereas the heart has will start, but keep it in mind that the heart will start beating by the third week, and this is very important for a pregnant lady, just to hear the sounds of her baby by the third week. So the right and left tubes will be forming the heart loop. This is the cardiac loop, let us call it. And the cardiac loop is having two entities, mainly two at their ends. The cranial end in here having the aortic arch, then the aortic pole, and the bulbous cordus in the middle. Here are the ventricle, and here is the sinus venosus. Later on, we shall call it, but the atria is coming in here. This is very important. This is by day 21. Complete diffusion of this, they are coming, those are becoming more truncus arteriosus. Distally to them, there will be this aortic arch and the the arterial pole in here. And this is the ductus arteriosa, the future ventricles coming, the sinus venosus in here, and the sinus horns, one to the right and one to the left, which is very, this is by day 22. The two endocardiac fusing here together, this is the cardiac loop, this is the cardiac loop with those, attached or connected or branching structures. Sinus venosus, this is the sinus venosus, and having two horns, the right and left horns. The bulbous cordis, which is this one, the bulbous cordis here, having the proximal conus and ductus arteriosus or truncus arteriosus distally. Truncus arteriosus distally to be differentiated, and the proximal conus. This is good to just keep this cardiac loop in mind and their different parts, because this is the future heart will be differentiated. We shall see. If we are going to the loop of the heart and the different parts, as we mentioned earlier in here, just we are having the cordis, the bulbous cordis in here, and the sinus venosus here. Just have those main big structures in mind, please. The bulbous cordis forms most of the right. Let us look now. Heart chambers will be formed. Forms the most of the right ventricle and parts of the outflow tracts for the aorta and pulmonary trunk. Coming here is this red one is the primitive ventricle, forming most of the left ventricle. Here we are coming to the sinus venosus, which will form the primitive atrium in blue, forming the anterior parts of the right and left atria. The sinus venosus here is having two horns, the right horn and the left horn, forming the superior vena cava and part of the right atrium. This is very important diagram, just to keep a diagrammatic representation of the heart full, the heart loop, and how being differentiated or segmented into its different parts for future forming of the full heart. And there is something very important during the folding, how the folding will be happening, lateral clockwise or anti-clockwise. So folding and rotating of the heart tube. Let us come again to the loop of the heart. Here the blackish one is the truncus arteriosus. And here are the two branches in here. Truncus arteriosus. Coming here, the cordus bulbus, the cordus bulbus cordis or cordus bulbus. Then coming here is the blue one is the ventricles. Coming here is the atrium, uh, you know, and coming here is the sinus venosus coming, for the whole to be differentiated into its two horns. So by day 22, here lateral folding will be the ventricles will start to rotate something like anti-clockwise, and this is the rotation of the ventricles. Just to the ventricles will move ventrally and to the right. The ventricles will move ventrally and to the right. The atrium will be moving dorsally and to the left, and this will give our normal position of our hearts in its left hemothorax. If this is normally, this the normal rotation is like this: ventricles moving ventrally and to the right, ventrally and to the right, and the atria are moving dorsally and to the left. If the heart loops, I mean rotating to the left instead from the right to the left, not to the right, there will be something called dextrocardia, and the heart of that body or that you know of this fetus will be on the right side, on the right hemothorax, and we are calling this dextrocardia. As you know, dextrocardia could be isolated dextrocardia or part on situs inversus, whether totalis or only dextrocardia on the right. Some people are having their heart on the right side. So this is the first congenital anomaly which we could have, and this is simply due to the cause that if the heart loops to the left rather than to the right, then the heart will be placed on the right hemithorax, and this picture is called dextrocardia. This is very important. This folding and rotation of the heart, the ventricles anti-clockwise, something like this, the ventricles will move ventrally and to the right, and the atrium is moving from dorsally and to the left, and this is giving the normal status or normal situation of our hearts in the left hemothorax. Exactly like this one, anti-clockwise, and the other one. Again, just to stress the idea, again, this is the looped heart. After looping of the heart anatomy, again, we are giving, this is the loop of the heart. Again, I am repeating some different diagrams so as to fix the idea in mind. Here is the aortic arch. Bulbous cordis is having two its terminal structures. Here is the conus. Look at the colors matching together. This is the conus. And here is our right ventricle, and here is the right ventricle, and here is coming the left ventricle, a little bit brownish or goldish, less dark in color. And here is the right atrium, a little bit darker. And here is the left atrium in here. And here is coming the atrioventricular canal, valves, of course, when being developed. And before that will be the canal in here, atrioventricular one. Again, please just keep in mind, ventricles move ventrally and to the right, giving the normal position of the heart in the left hemothorax, and atria moves dorsally and to the left. Repeating this just to keep this idea in mind and not to forget. By 30 days, what will happen in here? Here is the aortic arches on the right and on the left. We are having six sources in the dorsal aorta and here aortic arches, and each one of those arches is having certain structures coming from, and this is the arch. We shall discuss this at the end of this lecture. So atrial part is here is the atria being developing and are the ventricular early ventricles and the foramen in between. Atrial partitioning just began to happen by 30 days, right and left. Primary interventricular foramen, this is the primary interventricular foramen being still undivided. There is a communication between this and that. The outflow tract, the bulbous cordis and the truncus arteriosus is still undivided, but the proximal portion of the bulbus itself, uh, proximal portion of the bulbous cordis becomes trabeculated and forms the right ventricle trabeculated here, the bulbous cordis, being trabeculated to form the right ventricle, the atrioventricular canal, this canal here, this is the canal in between. Atrioventricular canal is still being undivided, and by cushions developed from the endocardium, this will be closed in the coming days intrauterine. But so, how the division of the atrioventricular canal did happen? You know, formation of this is started really by formation of what is known as atrioventricular endocardial cushions. This is the red rose-like cushions, growth in here, one in here and one in here. One dorsal and one ventral. This is the dorsal one, and that's the ventral one. This is, growth of those cushions will help in, just dividing the atrioventricular canal. This is achieved through the conversion of endocardial endothelium in the atrioventricular channel or atrioventricular canal into a mesenchyme that proliferates, and both are approximating each other, those cushions, to form what is known as the cushion of tissues, the dorsal and ventral. Those the dorsal and ventral cushions. Of course, this is controlled in utero by many factors. Among it is the retinoic acid, which is a vitamin A metabolite, very essential to be found without excess to the to, to the baby and without a deficiency in that. The dorsal and venous canals, this is starting to approximate solidly closed and dividing the atrioventricular canal into two channels really. The dorsal and ventral cushions fusing in the middle here to form a block of tissue to dividing the right and left atrioventricular canal. This is the the atrioventricular canal, and this is another atrioventricular canal, and those are the both atria. A future, you know, we are going just step by step to see how the chambers of the heart being divided. So by expansion of the tissues, dorsal and ventral cushions, as we said, around the peripheral V canal, dorsal and ventral cushions fuse to form the right and left canals divided by the intermediate septum. The septum intermedium, we are calling that. This is the intermedium, septum intermedium, so as it will be start dividing from this point, dividing the atria and dividing then the ventricles later on. Failure of fusion of those cushions will lead to what is known as persistent AV canal. Persistent AV canal by itself is a disease congenitally being found in some of the patients like Mongol patient or something like. There is something called remodeling. That's to say, changing the shape and structure of the heart. Remodeling of the right and left atrioventricular canal into alignment with the future right and left ventricles. And this movement is controlled by different growth factors. And if this didn't happen, some congenital anomalies like double inlet defects could happen in the embryo. There is something, this is a clinical entity which is found, as we mentioned, in Down syndrome. Here is the one chamber of the atria and another for the chamber for the ventricles. And we are calling it persistent EV canal. Clinically, it could be found in patients with Down syndrome. Trisomy 21. It could be found in those newly born babies, which is good to consider and to know that such a baby could have this syndrome. So assessment of the heart when in mother delivering a baby with the Mongol picture or Down syndrome to make sure this baby is having this entity congenital defect or not. Yes, it is. Now let us come to the atria, right and left atrium, how being formed. You know, firstly, we talked about the septum intermedium, which is being formed to divide to start division between the atria and the ventricles lower down. And we are having here this is the you know this is the atrial aspect and this is the ventricular aspect. Let us see how will it happen in the and this is the septum intermedium. The septum intermedium is formed of the atrioventricular canal being widened transversely to divide the atrioventricular channels to divide them into right and left halves by appearance of ventricular, ventral and dorsal atrioventricular cushions, dorsal interventricular cushions, and ventral endocardial cushion through the septum intermedium. Meanwhile, there is a septum primum, we call it in here. The septum primum which develops from the roof, this is the roof of the primitive atrium, and grows down to fuse with the septum intermedium. This septum will come to fuse with septum intermedium, and before a fusion, there will be something like called the foramen primum. And the foramen primum here is the space between the septum primum and, as we see in here, septum intermedium. A foramen primum is the opening between the lower edge of the septum primum here and the septum intermedium. This is very clear picture really. The atrium is now being divided, not completely, yes, but being divided by the to right and left compartments, right future, right and left atria. This is very important really, just to keep it in mind. This is the septum premium here, and this is the right atrium, and this is the left atrium, and the septum intermedium in here, and this is the interventricular. We shall talk about how ventricles are being divided, but let us now concentrate on the atria, how being formed, how being having two chambers in here in the next slide. So there will be some sort of degenerative changes that occur in the central portion of the septum primum. Septum primum will be complete in here, communication between the septum primum and the intermedium one, degeneration of the part of this septum, central portion of the septum primum, a foramen appears, and we are calling this as foramen secundum, secondary foramen, that's to say, foramen secundum. So the right and left atrial chambers are recommunicating again. They were fused together, and some degenerative changes occur, and now there is a recommunication between the right and left atrium. Another septum, we are calling it the septum secundum. This is the septum. That is the side of the septum primum. It grows down from the roof, again from the roof, from the roof. This is the septum secundum. This is the septum primum, and this is the foramen ovale, which will come later and talk about. Another septum secundum. This is the septum secundum. This is starting here, and in the next it is growing. The discussions are being coming more in length. Septum secundum grows down from the roof of the right side of the septum primum, and the lower edge, this lower edge of the septum secundum overlap the foramen secundum, which is this one, foramen secundum, in the septum primum, but does not reach the floor of the atrium and doesn't fuse with the intermedium, and the foramen ovale will start to be formed. So the foramen ovale, which is in this area, very important to know this, because it's a congenital anomaly. A baby could born with patent foramen ovale, and we might need to do something to treat that. So foramen ovale is space between the margin of the septum secundum and the septum primum. This is very important landmark, just to keep it in mind, explain it later. So before birth, this is the septum secundum. Let us come again. This is the septum secundum, and this is septum primum in here, and here is the foramen ovale, which is still found in here. Before birth, here is still there will be, this is the right side, the right atrium. There will be inferior vena cava opening, and the opening for the sinus, coronary sinus, as we drainage, venous drainage to the heart will be to the right atrium in here. And here is the what is known as the crista terminalis. You remember the crista terminalis when we were talking about the structure of the atria? A crista terminalis is the inner indication for the outer a groove of sulcus between the right auricle and atrium. This is the outside. There is a groove on the outer, so just corresponding to the crista terminalis being presented by the sulcus outside it, or vertically groove between the right auricle and the right atrium. So before birth, let us look at this picture. Very nice picture, just to keep it in mind. Before birth, the foramen ovale allows what was the function of this foramen ovale? Yeah, and during in utero, it is very important just to keep it in patent because the blood which is coming from the inferior vena cava is oxygenated blood will be shifted to the left atrium because of the higher pressure in the right atrium than the left atrium. So oxygenated blood has had to be entered will go to the right atrium from here to here enter the right atrium from inferior vena cava to pass into the left atrium. However, the lower part of the septum primum, which is this one, small one, serves as a flap-like valve. flap-like valve زي باب كوريدور بيسموه هذا أو يعني بيسمح it will allow blood to go from the right to the left and not from the left to the right, which is very important landmark during this is in utero really. But at birth, when the fetus being born, only there will be raised pressure in the right atrium, and this will prevent or close this foramen ovale by fusion of the primary septum and the secondary septum, which is very important, really. Yeah. So there will be complete separation of the right atria from the left atrium because the pressure in the left atrium, pulmonary resistance will be more. You know, it will be the lung will be inflated, and the alveolar functioning of the pressure in the right atrium will be in the left atrium will be more than the right atrium, and so this foramen ovale will be closed. So at birth, owing to the raised pressure in the left atrium, the septum primum is pressed against the septum secundum and fuses with it, and the foramen ovale will be closed, and this is the normal and natural. If it is still open, in a minor degree, accepted by clinical. If it is big, it will be manifested by manifestations, and surgery had to be done for that. The lower edge of the septum secundum, that one, seen in the right atrium becomes the annulus ovalis. Annulus ovalis, the lower edge of the septum secundum will be the annulus ovalis, and the depression below that is the fossa ovalis. Fossa ovalis is the site of the foramen ovale, just to keep it in mind, as we mentioned here regarding our presentations before. The right and left auricles or appendages later develop as a small diverticuli from the right and left atria respectively, just an outgrowth of the endocardium. Now, if we are to come to the ventricles, more or less the same diagrams we are to discuss in here. Here is the septum primum, and here is the foramen primum, and here is the septum intermedium. Those are the key structures in our developing how this will develop the two ventricles have developed. Of course, before it will be right and left atrioventricular canal, it will be one canal, and how will be divided. So muscular portion projection partitions. This is the partition. This is the muscular part of the ventricles. Projects upwards. It will come upwards from the floor of the primitive ventricle to form the interventricular septum. Gradual will be growing. Gradual will be growing. Just to keep it in mind, the interventricular septum is partly about two-thirds of it muscular, and the upper one is a membranous part. Just to keep it in mind. So this is muscular part, interverticular septum will be forming from the floor of the early ventricle. The space bounded by the concentric edge of the septum and the endocardiac cushions forms the interventricular foramen, and this is the space between. This is the septum, but and this is the big space We are calling it interventricular foramen. Going hand in hand, I mean simultaneously, there will be some sort of spiral subendocardial thickening. And by spiral endocardial thickening of the aortoconus tunnel, the aim for that is to form some sort of spiral aortopulmonary septum. That's to say something separating between the future aorta and the pulmonary pulmonary trunk. Meanwhile, the spiral subendocardial thickening in the bulbar ridges appear in the distal part of the bulbus cordis. Remember the heart tube. The bulbar ridges then grow and diffuse to form the spiral and the aorto pulmonary septum. This is very important. This is the right and left ridge. They are fusing together to form this spiral in the subendocardial thickening to give at the end this the aortic and the pulmonary structures coming. The interventricular foramen, this space, this big space, the interventricular foramen closes as the result of proliferation, cell proliferating of the bulbar ridges, and diffused endocardially with the endocardial cushions with the septum. This is the septum intermedium. This newly formed tissue grows down from the septum intermedium tissues growing down and diffuse with the upper edge of the muscular ventricle to form the membranous part of the septum. And here there could be some defect could happen congenitally, and we are calling that VSD or ventricular septal defect. The same structures in here, but it's a very important embryological accident to happen if didn't close completely clinical complications by by it is meant the VSD or ventricular septal defect. Significance of a closure of interventricular fluid. This is very important because each ventricle will do its function alone and each ventricle will be connected to its own structure. The left ventricle will be connected to the aorta and the right ventricle will be connected to the pulmonary trunk, separate trunks. If this didn't happen, or there will be a duct bigger than this one, or that one, there will be some congenital defects that did happen, which are expected to happen. About development of the cardiac valves, we do know that the heart is having four valves, two semilunar valves to the aorta and the pulmonary artery, and two atrioventricular valves. The valves are simply being formed after the formation of the aortopulmonary septum. There will be three swellings to each aorta and pulmonary artery appear at the orifices of both aorta and pulmonary artery. Each swelling consists of covering of the valve, two endothelial coverings, and in between the two coverings of endothelium, there will be loose connective tissue. Gradually, the swellings become excavated to the outside on their upper surfaces to form the semilunar valves because they are being full of blood when there will be some sort of filling of the ventricles. Coming to the atrioventricular valves, the tricuspid and the mitral valves, after the formation of the septum intermedium, the atrioventricular canal becomes divided into right and left atrioventricular orifices. This is, we know this before, but just we are mentioning again. Raised folds of endocardium appears at the margins of these orifices. These folds are invaded by mesenchymal tissue in between the two folds of the endocardium that later becomes hollowed out to form the ventricular folds. If there will be on the right side, there will be valvular cusps are formed about the right atrioventricular orifices constituting the tricuspid valve. But on the left side, there will be two cusps formed about the left atrioventricular orifice to form the mitral valve. The newly formed cusps enlarge and their mesenchymal core become differentiated into fibrous tissues, become more tough and more strength to withstand the dynamics of of the ventricles. The cusps remain attached at the intervals at the ventricles by muscular strands, and those muscular strands are very important, as we did see in the structure of the ventricles earlier. Those muscular strands become differentiated into papillary muscles and the chordae tendineae. If we are talking about the development of the big vessels, and but the roots of the proximal portion of the aorta and pulmonary trunk, again, this is another picture for the loop of the heart. This is very important. Endocardial heart loop. Let us look at it again. This is the bulbous cordis, and this is the sinus venosus. And the bulbous cord is here, and, of course the heart is being surrounded by the pericardium, and the pericardium is having serous pericardium and fibrous pericardium. This is as simple as that. And here is the distal part of the bulbous cord is having the aortic sac in here, and the arteries of the pharyngeal arches, which are, which are, you know, aortic arches will be forming about six arches at least, yes. Here is the truncus arteriosus, that's to say the distal part of the bulbous cordis. Coming here are the future ventricles, and in sinus venosus we are having the future atria. Here sinus venosus giving the and the atria, and here the horn of the sinus venosus, right and left side, the two horns, and here attached to it the umbilical veins and the vitelline veins and all of those common cardinal veins. Just to keep it. This is very simple picture for the loop of the heart. Just to keep it in mind. Bulbous cordis, sinus venosus. Here are the ventricles. This is the atria. This is the sinus venosus. It's two horns in here. And here the bulbous cordis is terminal truncus arteriosus, and its terminal part is the aortic arches. But of course, collectively aortic sac in here, and arteries of pharyngeal arches are there according to the number of arches we are having. The arches here, as we have mentioned in here, is the first arch which will go to the neck, the big vessels from the aortic arches. The second arch regressing esophageal artery, it will be, we are having two arches to the left and to the right, of course. And the third arch is giving the left and right common carotids here, internal and external carotid arteries. The fourth arch is given part of the aortic arch and part of the right subclavian artery. Sixth arch, I landmark it in here as a landmark to know what is before, what is after this. It gives on the left side the left pulmonary artery. The origin of the left is different from the left aortic vessels arch, and the right pulmonary from the right pulmonary arch in here, left pulmonary arch and ductus arteriosus, both of them in here. Just keep it in mind, and the right pulmonary artery. Here coming the seventh segment, we are having the left subclavian artery and the part of the subclavian artery. Here, the dorsal aorta, descending thoracic aorta, and just really for your status, just I like you to know the general plan for those for those arches. But try to know there is a left arch and there is a right arch. If you are talking about pulmonary arch, there is a left in here with ductus arteriosus and right pulmonary. Just to have to know at this status the general plans of those big vessels have been formed. It's important to know that. Now let us come to the clinical entities with those great vessels and some expected defects in the heart during the development. We are having a disease called atrial septal defect. That's to say there is defect between the right atrium and left atrium. And here is that defect still patent for Ramin ovale. And as we know, the pressure now in the left atrium is more than the right atrium. And some oxygenated blood will be go from the left atrium to the right atrium. If it is big defect, it had to be repaired. After birth, it had to be closed. If 25% small opening persists, there will be no problem. But we are to know that. The second congenital heart disease is the ventricular septal defect, VSD. Ventricular septum, as we know, it is formed. Part is muscular, most of it, about two-thirds, and one-third is the membranous part. VSD is less frequent than atrial septal defect and found in the membranous part of the septum. It could be measured by echocardiography and some other studies. It could be 1/2 centimeter, 2 centimeters, and there are clinical manifestations for that. A blood under pressure passes from the defect from left to right. This is from left to right shunt, congenital heart disease, causing enlargement of the right ventricle. There will be large defects. It had to be treated. If not treated, patient will suffer. It will be lost. The other defect is sometimes common, and as medical students, we like to have this nomenclature of tetralogy of Fallot. And by tetralogy of Fallot, it has four components really, and sometimes it could be five components if we add it to the patent ductus arteriole. But let us come to see how does it in this tetralogy of Fallot. Normally, the bulbous cordis becomes divided into, as we said before, becomes divided into aorta and pulmonary trunk by the formation of the spiral aortopulmonary septum. This is the bulbous cordis with its terminal branching paths. The septum is formed by fusion of the bulbar ridges. If the bulbar ridges fail to fuse correctly, the bulbar ridges, the septum between both of them, unequal division, there will be unequal division of the bulbous cordis may occur with the consequent narrowing of the pulmonary trunk. This is the pulmonary trunk, and there will be some sort of narrowing of the pulmonary trunk. A pulmonary stenosis, let us say, it will be called, resulting in interference with the right ventricular outflow defect. The anatomic abnormalities in the Fallot tetralogy are for tetralogy tetra 4. VSD, ventricular septal defect in the membranous interventricular septum. There will be stenosis because, as we said, during the spiral aortopulmonary septum unequally dividing the aortopulmonary a trunk or communication, aorta will be more and the pulmonary stenosis will be less. So there will be stenosis of the pulmonary trunk, and there are some levels for that. There is some sort of overriding of the aorta. Instead of the aorta coming only from the left ventricle, whereas it is overriding the right ventricle, so some blood still will come from the right ventricle to this ascending aorta. So aorta is receiving blood from both the right and left ventricles. We are calling it overriding of the aorta. There will be severe right ventricular hypertrophy. And secondary to more blood is coming to this ventricle, more blood, so it will be hypertrophy, so as to push more and more. Sometimes there will be some sort of patent ductus arteriosus, that's to say, the pulmonary trunk will be keep attached to the to the aorta. You know, this is clinically very pathognomonic. If we could have a baby being born and having some, we are calling this congenital cyanosis, that's a bluish discoloration of the baby. But this is specifically improved by squatting, that's to say decreasing venous return in the lower limbs, squatting position of the body corpuscle for the patients. The patients could improve. Of course, this is a temporary group, and this needs could be repaired, and it's easy for heart surgeons to go on. There is something called patent ductus arteriosus, as we mentioned before, and if it is patent and symptomatic, it had simply had to be closed if it is like this in here, patent ductus arteriosus. This some great vessel transposition, like instead of this aorta, this is the pulmonary trunk. This is the aorta. Instead of just only receiving blood from the left ventricle, it receives from the right ventricle itself. And this is the pulmonary trunk. Still, it is receiving arterial blood, blood from the left ventricle. I mean, oxygenated. So it is a mixed blood in here. So transposition of the, here receiving from here and there. Just a transposition of the great vessels. This is important for at this status I told you, please. This is for only just to widen your background in understanding the possible pathologies due to congenital anomalies in the heart. Just to know this, just to know at this status. No need to stress it too much at this stage. Something very strange. You could not hear about this before. We are having aortic arch anomalies, or just aortic arch on the left and sometimes on the right. There is sometimes double aortic arch. As we know, there is aortic arch and only three branches coming from the arch of the aorta. But we could have double aortic arch, the right side will be still giving the right subclavian here, the right subclavian and right common carotid, and here, and here. You could have some sort of right aortic arch. Aortic arch from instead of going to the left, it will go to the right and giving the branches to the patient. And this is very important if you discover a patient like that. So right aortic arch incidence is not high, but we are talking about 1 in 1,000. 1 in 1,000 is not very little, by the way. We could have some sort of right apparent right subclavian artery. This is subclavian support to coming from this side, from this right side. But here it could come just next to the left subclavian, right, and it will go just even behind it right here. And just to know, this is for you to know, as I said. There is something very interesting that we are calling co-articulation of the aorta or stenosis of the aorta. Stenosis of the aorta could be this is the ductus arteriosus, patent ductus arteriosus. Either it could be post-ductal arteriosus. I mean by because this is very significant. Or a pre-ductal. This is the ductus. So pre, just before it. Or just after it. After it, this is the commonest type of it. And some patients could do not bad with this post-ductal coarctation of the aorta because secondary to this stenosis, there will be some sort of dilatations of the arch of the aorta, and the collaterals in this area will go and compensate for the loss in this. Collaterals will work in here, especially for the blood supply to the upper part of the abdomen, to the neck, to the brain, to something. So it's not very, not very critical, but we are to know that. But very pathognomonic presentation of the patient in here. If you are measuring the blood pressure in the upper limbs, it will be higher than the pressure in the lower limbs because here is the descending aorta, thoracic aorta. So you are expecting the pressure in the lower limbs if it is coming from here down. So it will be something lower than the pressure in the upper limbs. This is very important. It's just to keep it in mind. And pathognomonic, if you discover it, you will be lucky. But before the preductal coarctation of the aorta, this is stenosis of the aorta, and here and this is fortunate it's only about 5%, and there will be some sort of stenotic part of the aorta, or, the arch of the distal part of the arch of the aorta, and those could be corrected surgically. And for the venous system, as we said in here, the superior vena cava being formed during the sinus venosus and the outrancus arteriosus in there. And during development here is the sinus venosus, the hoses are cardiac veins, vitelline veins, and here are the umbilical veins and the suture IVC in here. And this is very important just to know there is a venous system being developed this way. Some of the anomalies of the inferior vena cava, there will be some sort of sometimes double vena cava to the patients, double inferior vena cava. there will be absent in field in a cave out there. Just some sort of this is very rare, but it's good to know that, just to keep it in mind. Thank you a lot for this presentations. I know it's a long lecture, but most of but all the findings, at least from the clinical point of view, is very important, just to keep it in mind from this status. It is not too much for you, but if you know that, you will feel happy, and you like, just to remind him and prepare yourself for the coming uh, clinical years. The best of luck to you and all. Any question, please don't hesitate to call me back. Any